Okay, so welcome. Today we're going to talk about notifiable. This is our first notifiable conditions event for 2025. And I want to make sure that everybody can see the PowerPoint, the main page of the PowerPoint, and they're not seeing other things. All right, Loretta, thanks. My name is Kristen Hosey. I'm the health administrator here at Chelan-Douglas Health District. And today also with us is Dr. Wallace, who is our health officer for Chelan-Douglas, as well as Okanagan counties. And we'll have a special guest speaker, Elizabeth Austin, today. If we also have Garth Donald, but he is like in transit from is it SAMHSA conference. So if he pops on, great. But he has given Elizabeth all his notes in the event that he's unable to jump on today. So a little bit of housekeeping. So we're going to be recording this, and it's recorded with us in collaboration with the Central Washington Area Health Education Center, which is out of Wenatchee Valley College. So as mentioned, please sign in, write your name, your organization, title is great too, and then just please stay muted just during the presentation so that there's not stuff in the background. And then we'll take questions at the end. You can also drop questions in the chat if you're like me and you might forget, but we'll try to take those at the end. I also wanted to let you guys know that we do the notifiable conditions events once a quarter right now, and they're usually on the first Thursday. So the dates for the next ones are May 1st, August 7th, and November 6th. They're quarterly at noon. And always have a Zoom function to it, so you don't have to come in person, but we have been in person before at Wenatchee Valley College. Okay, so what are notifiable conditions? Today we're gonna just do an overview of what notifiable conditions are, and then talk a bit about how overdoses is a notifiable condition in Chelan-Douglas Health District, and then go into an overview of overdoses as well as the epidemiology of overdoses. We'll talk a little bit about our red cap reporting system, and then discuss what public health does for overdose reporting. So notifiable conditions. In Washington, there is a WAC that spells out conditions that are legally required to be notified to public health authorities if there's a suspected or confirmed case of a condition, and that's WAC 246101. You can find the whole list there. Folks that should be reporting are healthcare providers, healthcare facilities, laboratories, could be food service establishments, childcare facilities, school nurses report conditions, and depending on the condition, we may also get reporting from veterinary facilities as well. So really kind of these are the big ones that would report to us. Why is it important? So surveillance is a super important part of what we do for public health. If you look at this, the 10 essential public health services circle, you can see that there's categories on the outside. It says like assessment, policy development, and assurance. But underneath it, that very first section that's red and orange is about assessing and monitoring population health and investigating, diagnosing, and addressing health hazards and root causes. And the point of that is really to be able to see what conditions are popping up, and that way we are able to describe the trends that are happening, figure out how to control the source of infection to prevent infection and disease, and as well as like educating the public and policymakers, as well as healthcare providers on what is happening in our community. So for notifiable conditions, there are 4 levels, and that's again for our healthcare providers. There is the immediately let us know level. Please call us and speak to a live person. You can call our agency phone anytime, and it will direct to an after hours call center where you would leave a message if it's like 10 at night, and then they'll call one of our on-call staff who will give a call back and follow up on an immediately notifiable condition. There are some conditions that should be reported within 24 hours. So there, and then there's some that you can do, say comes in on a weekend, you can wait till Monday, it's a 3-day business day one. And then there's some that can be done within 30 days of either suspecting the case or having a lab confirmed example. So for immediately notifiable, these are things that we want to jump on real quick, and that's why you want to let us know. So something that's very infectious, like measles, or something that requires us to move and mobilize some other agencies and get like antitoxin or something like that. Those are the things that we want to help coordinate that process. So for another caveat, and this is my last slide, and I'm going to turn it over to Dr. Wallace, our health officer, to talk about this more. As part of the duties of the local health officer or the local health jurisdiction, each local health officer may require the notification of additional conditions that are of public health importance that are occurring locally in that jurisdiction. So in 2019, overdoses became a notifiable condition for Chelan-Douglas Health District. It's not on the list that is on the initial WAC for 246101, but as mentioned in 105 4D, if there are concerns that are specific to an area, say there's like PFAS or something else, there might be a request by the health officer to make those conditions reportable, and that's what we're going to talk about today. So I'll turn it over to you, Dr. Wallace.
Great. Kristen, thank you so much. Good afternoon, everyone. I think someone in the chat said there might be some other folks in the waiting room. Do other folks need to be let in? If so, do that. Great. Well, good afternoon. I'm really excited to focus on opioid overdoses or all substance overdoses for this conversation today. I'm Jimmy Wallace, as Kristen said. I'm the health officer for Chelan-Douglas Health District and also Okanagan County. I've been a family physician for 12 years working in the region and work in both outpatient and inpatient facilities, and do provide treatment for opioid and other substance use disorders, and try to organize better care in our systems and for our services. And have really enjoyed the successes we've seen, but certainly feel like we've got a lot yet to be done. So in 2019, Dr. Frances Collins, the health officer of Chelan-Douglas Health District at the time, let's see if we can mute everybody. Thanks. The health officer at the time made all overdoses a notifiable condition. At that point in time, we had a regional opioid stakeholder collaborative that was very active, supported by North Central Accountable Communities of Health, drew in a lot of stakeholders, and there was recognition that we needed to do more to assist people in getting treatment. So that the systems created at that time were really geared towards reporting for the benefit of getting folks into treatment. So it was done so in collaboration with the Center for Drug and Alcohol Treatment. And that collaborative effort was really strong, but it did not serve as a great surveillance tool. And over the past 5 years, it's been less and less well utilized. So we're improving those systems to make it easier, to make it a better tool for surveillance, so that we can support the work that many of you do in improving your systems and collaborating. We do have state level data, and we can draw some good information from that. So on the right, you can see that especially Okanagan, Chelan, and Grant counties have a high rate of opioid overdose deaths. And regionally, we see a lot of emergency room visits, EMS transports, hospitalizations, and especially injury deaths that are due to opioids. We also have evidence-based strategies and and targeted ways we want to make improvements. And one of those specifically is improving data systems to monitor in real time the trends that we're seeing and to help our partners respond. You'll notice that a lot of the state level data dates back to 2022, 2023. And so there's a huge lag in what we're able to receive and how we're able to respond. Next slide, please. Again, the data that we do have shows, I think, what many of us are experiencing. We're seeing a rapid rise in overdose deaths, specifically related to opioids and synthetic opioids like fentanyl. More and more of those deaths are occurring because of a combination of stimulant and opioid overdoses. Overdoses due to heroin are down, and then deaths due to prescription opioids now make up a small proportion of overdose deaths, whereas a decade ago, we saw a lot more prescription opioid deaths. Next slide, please. One win that we've seen across the region is that dangerous prescribing practices for prescription opioids have come down considerably. Healthcare providers across the region have worked hard to reduce prescribing practices that lead to opioid use disorder and overdose deaths. Next slide. And at the same time, we've seen more treatment services pop up. So many more providers now are offering medications for opioid use disorder. But despite this improvement, we're still not keeping up with the overdose deaths that we're seeing. Next slide. Interestingly, we see that despite the increase in overdoses and increase in deaths, we're not seeing an increase in emergency room visits for overdoses. Next slide. We are seeing an increase in EMS responses for opioids. And then next slide. But we're seeing a decrease in transports by those EMS services to emergency rooms. And next slide. Some of that can be explained by the amount of naloxone that we're getting out. So these are small numbers, and so you see a lot of variation in that data. But in the past year, we've had a general increase in the number of naloxone saves. So in summary of those last 5 slides, we are seeing fewer people go to the emergency room for opioid overdoses. We're still seeing a lot of EMS traffic and increasing calls for opioid overdoses, but oftentimes because of naloxone and because of the good work being done by our EMS and emergency personnel, people are oftentimes being saved, but then declining transport, not feeling like they need to be transported. And so a lot of opportunities we have to serve those individuals are missed because they're not coming to emergency rooms. Next slide. So one thing that we certainly hear from healthcare providers and folks that are working with recovery support services is that the complexity of overdoses is increasing. Overdoses are really hard to treat. For opioids, we have naloxone, and oftentimes that's successful. But it is not a successful treatment over the long term for repeated overdoses. When mixed with methamphetamine, cocaine, benzodiazepine, xylazine, the capacity that healthcare providers have to reverse the effects of opioids is limited. And so we see increasing overdoses because of multiple substances being involved. At the same time, reports we're getting is that more and more substances that are obtained illicitly have fentanyl mixed in with them. And so people who think they are taking methamphetamine, cocaine, other medications without an intent to use opioids are getting enough fentanyl in that supply to lead to an overdose. Next slide. We also know all too well that it's not always just about the substance use disorder or the actual use of a single substance. but that the overall health of individuals is challenged when they're using substances. So the psychiatric comorbidities that come along with substance use disorder are oftentimes caused by the substances that are being used. So the whether it's opioids or methamphetamine or any other substances, oftentimes those substances wreak havoc on the brain's chemistry. The neurotransmitter systems are deranged, and psychosis, mood disorder, cognitive impairment is caused by the use of those substances, such that individuals are not able to navigate their lives and avenues towards recovery as effectively as they otherwise would be. People also have coexisting behavioral health conditions. Oftentimes, that leads individuals to use substances when they can't access treatment for behavioral health conditions. And so those behavioral health concerns are interchangeably related to substance use disorder. We see a lot more infectious disease among people that use substances, and chronic illnesses are worse among individuals that use substances. All those things need treatment, and oftentimes are more difficult to for access and treatment when people are using substances. We also see increased injury and self-harm behaviors among people that use substance use disorder. And so care for individuals with substance use disorder needs to take into account the environment that they might be in, more dangerous environments, more likely to have experienced domestic violence, more likely to experience suicide, more likely to experience homicide themselves, and a higher rate of motor vehicle deaths. And then with so many conditions we see, but especially with substance use disorder, there are social determinants of health that are unmet by individuals using substances. So when housing, employment, food security, transportation needs can't be fulfilled, it's all more difficult to access recovery services and thrive and succeed in recovery services. So it becomes a much bigger picture with a much more much greater need for care than just treating the use of substances. Go ahead, next slide. We do, as I said, have access throughout the region to treatment for substance use disorder, but multiple areas of our region have less access. We've been able to set up a behavioral health and medication-assisted mapping project with Thriving Together. And you can see on the map below, generally along the river corridors throughout our region, there's better access, but as you drift farther from population centers, we don't have as good access across our region, and individuals don't have the greater ease of accessing clinical services for medication-assisted therapy. We also don't always have every door is the right door way of providing care. So depending on what clinic you go to, what hospital you go to, or what social service organization you go to, there may or may not be an easily accessible source of treatment for opioid use disorder or other substance use disorders. So in creating better surveillance systems, we want to be able to map out resources and map out where we need to identify, target, and provide greater opportunities for individuals to access care. Much of that is building bridges between emergency rooms and substance use disorder programs, ensuring that if people are hospitalized, they can be discharged easily to the care of somebody that can help them on their road to recovery. We have a growing program for individuals who are incarcerated so that when they are released, they can be released into the care of a substance use disorder treatment program. And then our recovery support services are growing, and we need to invest more in the individuals and the organizations that are working towards supporting recovery. I know a lot of folks working in those spaces are on the call. I appreciate how many people are here. And I certainly want to have time for discussion and for people to share what they are doing and for people to share with us where you see gaps and where we can use a surveillance system to better quantify and describe where we can improve systems. We do have some local data that we can collect. And so I'm going to turn it over now to staff members. I think Elizabeth Austin has slides from our local surveillance that we are able to maintain. And then hopefully Garth will be able to hop on and talk about work that we're doing in the health district. So Elizabeth, I'll pass it to you.
Okay, great. Thanks, Dr. Wallace. Okay, so the data that I have is primarily regional because looking at some of the numbers, we wanted to make sure that we abided by the small numbers guidelines. But I wanted to show this slide that shows the age-adjusted rate of all drug and opioid overdose deaths per 100,000. This is for Chelan-Douglas, Grant, and Okanagan counties here from 2019 to 2023. And so 2023 is the most recent year that we have data available on overdose deaths. At DOH, they do a death review process, and so it takes them about 12 to 18 months to fully process that data and review it. But you can see here there's a definite increase since 2019, and there's reason to think that the rates for 2024 would also be higher than 2023. Next slide. And I also wanted to show the number of EMS providers that report data to the Washington EMS Information System, otherwise known as WMSIS. And so basically, WMSIS is it's a statewide database that contains reports for pre-hospital electronic patient care records. And so participating licensed EMS service providers report overdose events to this database. And this helps to just support surveillance of events that are happening statewide and also on the regional and county level. And ultimately, this data helps us identify quality improvement measures and support local and regional efforts to target areas where health outcomes could be improved. And so this data shows the number of reporting providers of EMS. So there's 42 total licensed providers. Again, this is June 2024 through December of 2024. And you can see that there aren't as many reports coming through. And so one of the reasons we are implementing some of these surveillance tools is to improve access to reporting to Chelan-Douglas, that we can gather more information. Next slide. And just to talk a bit about the work that we do here at Chelan-Douglas, Garth Donald is our mental health and substance abuse coordinator here at CDHD. And so when we receive overdose reports, he looks at the time and the geographic area where the event occurred, and he's looking for potential clusters or spikes in overdose activity to try to identify, what is the source behind this spike in some of these overdose events. And then from there, he also notifies our partner agencies, and that includes CAFE, the Recovery Navigators Network, Lighthouse Day Center, Wenatchee Rescue Mission, St. Francis, and Catholic Charities. And so the goal with notifying them is to encourage the spread of harm reduction knowledge and increase specific types of outreach to different populations in our area. And he's also looking to identify trends in the illicit drug supply because some of these overdose events don't present as a typical overdose in some cases. And there are, oftentimes newer illicit substances that are making their way into that drug supply. So trying to sort of focus on just the causes behind the trends that we're seeing. And then also the reports are shared with the Drug and Alcohol Treatment Center of Wenatchee. They have been active for years in providing services for patient follow-up to treat substance use disorder. Next slide. And so just to talk a bit about overdose event reporting. So as mentioned, overdose events are going to be considered notifiable within 24 hours. And below is the case definition for categorizing an overdose. And then we also have developed 3 different methods for reporting, one of which is new. We have the REDCap online survey that's in development currently. We'll also have an updated fax form that you can send to us. And then also you can contact CDHD by phone to report overdose events. So the goal is to increase reporting and work with our local healthcare providers and EMS services just to try to gather more information on these events so that we can, hopefully target specific populations and identify areas that are in need. Next slide. And so how it will work at Chelan-Douglas is if you'd like more information, you can reach out to our CD-EPI team at the email address located there. You can also contact Garth Donald or myself. We've been working together closely just to develop the reporting mechanisms, and we're happy to answer any questions that you may have. And I believe that is the end of the presentation.
Great. Thank you, Elizabeth. So I think it's obvious Chelan-Douglas is really making opioid overdoses prevention and trying to strengthen opportunities for recovery a top priority. Our Board of Health has discussed it the last 3 months. It's been a topic of consideration, and the board would really like to see us improve our actions, and then recognize that there's a lot of work being done across the region throughout our communities, and really want to strengthen and contribute to that work that's being done. So we've got a lot of time. I'd love to hear from participants on the call. Introduce yourself, share a little bit about what your organization does, and share with us thoughts about how better surveillance systems could improve the work that you do. I see some familiar names, so I could call on people too.
This is Laurie Jones from Okanagan Public Health District. And similar to what Chelan-Douglas is doing, we have an online report form. We also receive reports from our 3 hospitals and EMS. And so this is a really good thing. As it's already been stated, this is a great surveillance tool, and interventions can be planned around this eventually. So thank you, Kristen, Dr. Wallace, Garth, and your whole team. This is a great regional effort.
Thank you for that, Lori. Do you want to share a little bit about what Okanagan County Public Health is doing, or some of the programs that it's offered over the past decade and more that are in response to the numbers that we see?
Certainly. So we have had a harm reduction syringe services program since 2006. We have we do an assessment form. What we've noticed the last year or so is the lack of participants due to fentanyl not being injected but smoked. And so that's been really concerning, because our harm reduction program, not that injecting is a good thing, but it gave us an opportunity to one-on-one with clients and promote treatment options and really make sure that their health and for example, wound care, that sort of thing, was being met, and conducting referrals and that sort of thing. With the advent of smoking fentanyl so often, we've had very few participants. One of the things that concerned us was, of course, overdose deaths, and we purchased a Randox multi-drug testing machine for our coroner, so that they could get results rather quickly, because it was taking months for our coroner to determine cause of death when we suspected overdose, and eventually we can review those deaths. So that's one of the things we're doing. The other thing is we're, besides the form, the overdose form, like has already been mentioned, with Narcan being in use, a lot of people are not being transported to the hospitals, and so we had no way of knowing what was going on. So we get the report from our dispatch center for overdose. And what I can tell you for Okanagan County this month, or the month of January, is the highest I've ever seen calls for overdose. Last year we had 14 calls for overdose in January. This year it's 32. And so we've more than doubled the number of calls to 911, which is extremely concerning and something we need to address. So that's some of the things we're trying to do and encourage not only our healthcare providers, EMS, and our local, our county commissioners are involved as well. And so, yeah, we're trying to get on top of things.
Thank you so much for that. It's been really impressive to see what Okanagan County Public Health has done for almost 2 decades now, recognizing the severity of this and intervening in some really novel and unique ways. But it's I try not to let it be disheartening to see that despite all that effort, there are more calls this past month than ever before for overdoses. I guess a hope I have is that people are, every call to 911 is a call for help, and people are recognizing the need for help. And the data shows how busy our EMS services are. If we can strengthen their work in any way to help them help individuals access care, I think that's a high priority area. I know a lot of EMS services elsewhere have piloted buprenorphine leave behind programs so that people can initiate treatment themselves. Oftentimes after an overdose, a person has the need to fulfill the withdrawal that they immediately have after receiving naloxone, and to be able to use buprenorphine for that purpose instead of going back to fentanyl or something else is a step in the right direction. I think we can also ensure that EMS services know what treatment services are out there so that they can also leave behind more information to individuals about how to access regional services.
The other thing I wanted to mention, if anyone knows anything about, I'm following it rather closely, is the GLPs 2s for the potential for addiction. Those are the Ozempics and Wegovy's, and those there's some real promise in the addiction world with those. So to be continued.
Well, thank you for that. I'll certainly look that up. See, Mike Battis has his hand up.
Afternoon. I thought I'd maybe just introduce myself. My name's Mike Battis. I'm the director of Ballard Ambulance. I've been in EMS in the Wenatchee Valley for, well, I guess this is my 26th year. So I thought I'd maybe give a little bit of a insider take on what we're experiencing. Um, Fentanyl specifically, narcotic overdoses in our area is a multiple time per day occurrence that we're seeing. A lot of them don't get captured as far as being transported into the hospital because Narcan is so readily available. It's pretty commonplace for us to show up on a scene of an overdose and the the person that is overdosed and the bystanders that are with them oftentimes have given 3, 4, 5, 6 doses of Narcan before we've even arrived. And we've had some pretty like eye-opening moments on that. I mean, I can think of one here in the last month or so where we get toned out to a cardiac arrest, CPR in progress. So we've got a lot of resources going. And this happens almost on a daily occurrence. And then before we get there, usually the Narcan's starting to circulate a little bit, working, the patient's starting to work or wake up. But one of them that was kind of like just a gut check to me is we're responding to literally a female that is CPR in progress. And we get updated just as we're about to pull away on the scene by Rivercom that the patient is awake and getting into her car and driving away. It was like, oh, okay. So, to me, something that I think we need to take a harder look at is maybe actually lowering the dose of Narcan. And it's something that we're really stressing with our crews and EMS in general. And I know that that sounds scary on the surface, but where it benefits us and the value that we see in it is we would like to get to where we are giving Narcan in a dose that's appropriate to restore ventilatory status. They're spontaneously breathing on their own, but they're not necessarily awake and making decisions again. You talked briefly, in the opening segment about how that the repeated overdose and this long-term substance abuse just, perforates throughout the community and into all sorts of other problems with, social services, MHP problems, all these things are just precipitated by these chronic overdoses. And I really think that our approach of trying to just get them to where they're spontaneously breathing, then we can adequately oxygenate them, we can take care of them in a controlled setting, get them to the hospital as they're waking up. Now they're in a controlled environment, their social services readily available. We can get that patient on a course to recovery that's far better than getting in their car and driving away before we ever even get there. We are going to start in our area a buprenorphine program and an Narcan leave behind program. That's something that the state has actually stepped in on. I just had a meeting about this yesterday. The state's actually stepped in, made a lot of resources available to EMS throughout the state, and is actually starting to push to actually require that MPDs come up with a program and some protocols for some leave behind programs. So I think that's, positive news going forward. WEMSIS actually just became a mandatory program. So hopefully we get a little bit more participation. It's no longer voluntary. So I think that could help. Now, a lot of those agencies that weren't reporting currently are your very small rural districts that don't see a lot of call volume anyways. So I don't think we're going to see a dramatic change in the numbers that way, but we should be able to see a little bit more. But that's kind of the approach that we're taking. We're going to do some things in our near future of like getting first contact pulse oximetry on people to really try to drive home to our providers that, you're showing up on this overdose and somebody's got an SpO2 of 50% or 70%, and that's pretty catastrophic. And we're getting this. My biggest fear with EMS providers and first responders across the board, law enforcement included, is we're seeing it so much that we're almost getting callous to it. And we're not really taking a step back and realizing the gravity of the fact that this person was just apneic for the last 5 or 6 minutes. I mean, most certainly if we had somebody that drowned in a pool that was 5 to 6 minutes without air, CPR in progress, even if they were awake when we got there, we'd take that very seriously. We don't do that with narcotic overdoses anymore because we're so used to seeing it, and we've just created this kind of callous on society. And I think the dependence on Narcan is contributing to that, or the availability of it. So that's kind of going to be our goal, is maybe try to lower that dose a little bit.
Yeah, I'd love to meet with you and talk more. I think, yeah, that appropriately, using protocols that are going to increase the ability to provide care, provide transfer of care to get people into treatment programs is certainly something that's worth exploring. Another EMS director that I've talked with has spoken to the duration of time that individuals are anoxic or hypoxic, and what long-term effects that must have. That, the longer someone's brain goes without oxygen, the longer it is damaged and destroyed. And then the expectation for people to have a complete cognitive recovery from that event is a huge challenge. So yeah, I definitely want to support the work that you guys are doing, and would love to follow up with you.
Perfect. I'll put my email in the chat for you.
Any thoughts from others on the call, or you want to share wins that you've seen, or success that your organizations have experienced or want to share with others? Anybody from Grant County want to share what you guys are seeing or doing, or needs that you guys see exist across the region or in your corner of it?
Hi, this is Maria. I'm stepping in for Mariah, who couldn't be here, as I'm home fighting pneumonia, so I apologize for my voice. But kind of similar to what Lori said, we have seen a decline in our SSP program as people have gone more into the smoking of the substance. So we've done more boots to ground, kind of just working to get Narcan out into our community. Doing more targeted outreach. We have taken on a little bit of heat from our political partners in our city, which we had not had for the last few years. We've had an SSP program since 2018, have not had any issues with our elected officials, but this last year we have really taken some heat from it, and with that the community as well. So we have worked hard to just kind of work through that and continue our work as needed. We're expanding to some little other communities, doing a more of a mobile SSP, which turns into basically more of a Narcan distribution, but still trying to connect with those vulnerable populations, visiting our sleep center, setting up at the food bank. We'll get people that go there, looking for resources as well. So really still trying to get out there as we can.
Great, Maria. Thank you so much. And thanks for chiming in and contributing, even though you're not feeling 100%.
Oh, of
really
course. Thank you for
that.
the opportunity.
Yeah.
I really appreciate that too, because I think most of our presentation was on the surveillance side. We do have folks here at Chelan-Douglas that are doing more of that. So very similar to what you were talking about at Grant County, outreach, communication. And really have to say that the biggest thing that has been a benefit to being able to do that was the fact that we got the funding to be able to hire positions like a substance use coordinator, like Garth's position, and other folks that can do more of that outreach and communication work. So it is definitely something that we've always had as a community. Like, like at least before 2019, because 2019 is when we started wanting to survey it, right? And get it reported. But it's been the last community, like 2 community health assessments that we've done, it's been in the top 5 of things that the communities wanted to address. So having that that support to be able to this year is the first time we've had a mental health and substance use coordinator, even though that's something we've wanted, because we've been able to get foundational public health services funding for it. So I see like Anthony's on here. He does some outreach work, and we do some trainings on like how to administer Narcan. We have a couple vending machines that sounds like a vending machine. It's not like you have to pay, but it's the machine so that it's not just a basket that people like pour all the Narcan into. But yeah, so it's good to hear some other options that are out there that we can coordinate with or do similar work. So thanks.
Yeah, I know the Narcan vending machines have been a success of that. I would say it sounds like in most places where they're set up, they're heavily utilized, and they're also similar to the syringe exchange programs. Also places where people can get more information about recovery support services and other options, not just for treatment, but for other services that folks need to access. Is anyone else on the call that's been working with the Narcan distribution and vending machines that want to share a little bit about that work?
Hi, Dr. Wallace. This is Crystal Eshelman with Carolina Behavioral Health. We've been
Did
doing.
you know I was asking you that question?
Yeah, we've been working with the Narcan vending machines for a couple years now and have seen really great success with being able to get Narcan out into the communities. We have been trying to collect data on their usage as well, which, you know, it's really difficult to collect that data, but we've been successful with some of the survey tools that we've used. And I think just a couple things to share about that. We started out with like you know, what a normal vending machine looks like, a large machine, a large footprint, and have had some partners that have looked at using like the old newspaper newspaper stand things where you buy them, but just putting Narcan in those and being able to distribute it that way, which is I think it's a really good option for some of our smaller communities to be able to get it out into more outlying areas. And then the other thing that I think has been really awesome, especially in our North Central region, is the engagement that happens at some of the sites and being able, you know, it is very low barrier. People can come in without talking to anybody and get Narcan, but they also have the opportunity to engage with the recovery coach and, you know, it's kind of, you know, a doorway into services. Sometimes, not everybody, but at times it happens that way. So.
Mm-hmm. And they serve as places where people know they can go. They might not want services at the moment or might not want to engage at the moment, but they know this site is a place I can go or encourage someone I know to go when they're ready. I think one key theme that I hear so many people is expressing is just to be there and be ready whenever anybody shows up and is ready.
Mm-hmm. Absolutely.
Great. Thank you. And thank you for the work that you're doing.
Yeah. One, I think, barrier that we see or challenge is that we've been able to fund these with ARPA funding that is ending in September, as you guys may know. And so just ongoing funding, you know, Narcan is expensive. And we continue to look for, you know, graded funding opportunities and funding from the state. And we'll continue as much as we can, but we're definitely looking for partnerships in that.
Yeah, well, that's an unfortunate place to be in, but let's use it as an opportunity to partner and to find ways to support each other and continue to grow these services. We certainly don't want to lose any.
Great.
Anybody from clinical settings or healthcare on the call want to share experiences or successes or ways that surveillance systems might be able to support the work that you do?
Retta Stover from the Center for Alcohol and Drug Treatment. And, we've seen some successes. Part of what has been very helpful is the overdose reporting. Certainly, it was better before COVID, and COVID kind of wiped it out because that, overshadowed, this epidemic. But it's been very valuable information when patients present and we have an awareness that they've had an overdose that maybe they are not reporting to us, but we can help, with interventions. And so we have seen success in that. The other thing that we're doing is we're partnering with the health district and with Carillon, and providing Narcan to everyone that walks in that is asking for service. Whether or not they follow through with services or not, we're offering Narcan right up at the very beginning. And that's in our outpatient. And then as far as our detox and in our residential inpatient, we offer it right up front, and then we put it into their luggage so that when they leave, even if they end up not completing treatment and leave under, against medical advice, it's in their luggage. They've got it. We're not asking them at a time when maybe they're, not in the right headspace to want to take that. And so, that's been valuable as well. And then not only the patients who are accessing services, we're offering it to their family members. So the people who are surrounding them that we think probably would have more the opportunity to engage and use it. So it's been great. It's been a great partnership, and trying to have an impact on interventions with people.
Yeah, great. Thank you so much. I think the initial partnership to make this reporting system possible with you guys has really led to strengthened services, and our hope is that we can make it even better, and really appreciate the work that you guys do. There's a lot to learn from your organization, so thank you. Well, we can call it there. Kristen, closing words.
We will take this video and we'll plug it up onto our CDHD website under the provider page. If you are interested in keeping up to date on any of our notifiable conditions, events that are upcoming, you can sign up, you can send us an email, you can drop your name in the chat and tell me that. And then you'll be notified when we have our next one. We usually kind of decided about a month out from the events, just based on what's going on in the community at the time. But if there are topics that are notifiable conditions that you guys would be interested in, we always like to hear from folks that are interested in learning more. Because a big part of the goal of this series is so you guys know who we are and how to tell us if you have a condition so that we can help you, and to try to prevent spread, to try to prevent injury, illness, death. That's that's our main mission here at Chelan-Douglas Health District. So reach out, and if you want to stay connected, you can drop your email in, and I'll work with Maria Christina to get you on the listserv. Okay. Otherwise,
Thank you.
yeah. Have a great day, everyone.
Thanks, everybody. Take care.